Just to continue, there's a few things I want to point out for the last few slides here. Make sure that you're really clear on the use of monoclonal antibody drugs such as Humira. There are a lot of things that in teaching a patient to use that, you want to make sure that they are aware of their heightened risk for infection. The drug itself, even though it's given in an injectable form, can have some side effects like nausea. And so the patient needs to be particularly aware of that, as well as their infection risk. If they have a type of infection, they need to make sure the doctor is aware of that. Maybe it's something not related to the Crohn's disease at that point in time. And so the doctor needs to be aware of that. You also will see glucocorticoids such as Flagyl given if the patient has developed a fistula or an area that communicates between the intestines, creating a fluid buildup. The Flagyl kind of will help to control that a little bit and control the infection related to that. Other things that you want to focus on with Crohn's disease, because so many areas of the entire intestinal tract are affected, the patient needs to be on a very high calorie, high protein, high vitamin type diet to kind of keep their weight up and keep them, having the highest level of nutrients. They also need to be on low fiber meals, which is different than some of the other diseases that we've talked about. They do need to avoid caffeine and alcohol. Again, they may be put on total parenteral nutrition and be MPO to let the bowel rest, and again monitor glucose levels every 6 hours. They might be put on nutritional supplements like Ensure or Sustacal in the hospital. And then one of the key things with fistula management, if they have a fistula that is draining open to the outside of the body, I'll show you some pictures of some wound manager devices collection devices that are used. And the key there is that content of that fistula material is going to be very acidic. And so it is very corrosive to the skin. So you want, at all cost, you want to really have one of those wound managers that I'm going to show you very closely covering up any intact skin around wherever the drainage hole is, so that not only so that the seal is good and it doesn't drain over the patient from a embarrassment standpoint, but also because the acid content in that fluid from a fistula can really erode the skin on the abdomen and tear it all up. And then you don't have any intact skin to really have the device adhere to. And you'll see some pictures of what that looks like in a minute. Here's a picture of kind of a fistula. You can have a fistula that opens between, a hole in the intestinal wall that drains under the skin, causing, peritonitis can be between the skin and the intestine. You can have it actually accumulate and cause an abscess or peritonitis, but it also can drain through the skin and create a hole where it actually drains to the outside, and sometimes surgically that's done to allow it to drain so it can heal up, and then you let the bowel rest and allow that to kind of clear itself up, and like we do with many wounds, kind of let it dry itself out. And then you see on the right an example of what they call an enteroenteric, which means where a fistula has developed between two intestines that kind of communicate with each other. And as you can imagine, this could really cause blockage. It can cause a huge pocket of infection. So just when you're thinking about fistulas, think it can be different ways that the erosion of the intestinal wall has occurred and things that can come from that. Fistulas often come usually as a complication of some type of abdominal surgery. 15 to 25% can just evolve spontaneously because of intra-abdominal inflammation or infection. These are some of the risk factors for fistulas. Surgical procedures like to treat cancer, inflammatory bowel disease, like the old LOA that I mentioned, license of adhesions, or sometimes with peptic ulcer disease, Crohn's disease and ulcerative colitis, diverticular disease, radiation when it's done to the abdominal area, other types of malignancies, either from gynecological areas or pancreatic areas, appendicitis, perforation of ulcers, abdominal trauma like gunshot wounds, and even an aortic aneurysm. But lots of different causes that can cause fluid to collect and or drain outside. Here are some pictures of ones that are enterocutaneous, meaning that they are draining either under the skin and then through the skin. And you can see in the picture to the left how it can create a pocket in the skin wall itself, and then gradually erodes enough through. And you can see the wound manager that is looks like an ostomy, but in reality what that is someone has a fistula that's draining, and so they have it set up. And that's what I was trying to say is, if you look at the picture at the top, you see where someone's got a fistula that's draining, but you see how red and irritated the surrounding areas are. And that is because, that bag has not been put on there with enough of an occlusive seal around the edge to where some of that liquid from the fistula is drained underneath it or around it and has eroded the skin further. So trying to keep that put on there precise, and if it leaks at all, replace the whole thing is your first action. You don't just patch it up with a bunch of tape and hope that it just kind of stays, because what you get is very erosive liquid draining underneath the bag and all onto the skin, creating more wounds. This is just a picture of the diverticuli that can occur. We don't get tested on that, but if you do see that terminology, it's kind of like little pockets that occur in the colon. Last few things, I'll let you all read through this in more detail. But diarrhea can be issue of frequency or volume or the amount of fluid in the stool. In general, water and electrolytes are lost due to dehydration. Diarrhea, is really not a normal thing, and causes you not to really absorb nutrients and fluids like you normally should. So you want to treat the underlying cause. Other things that y'all have probably seen, we do collect stool specimens. It must be a very liquid stool if we're testing for C. difficile. We can send stool to the lab to test for occult blood. Sometimes you can do some test on the floor to see if there's any blood in the stool. That's a quick test, and then you send another stool after the fact. People who have constant diarrhea, they will recommend what's called a BRAT diet. I'll let you look that up and just kind of see. But recognizing that when people are dehydrated, the biggest thing is, controlling the diarrhea. If it's a infectious process, giving them antibiotics. And then the primary thing is, how has it affected their fluid and electrolyte balance? Are they having a ton of liquid out and not much in? What's their electrolytes look like on a BMP? lab work. And then do you need to give them magnesium or potassium replacements to kind of counteract some of that? And the other key concern is what we were talking about in class is hypovolemia, because people can, suddenly they had a normal blood pressure, but they've had so much diarrhea and they're so dehydrated that you go to check their blood pressure and now it's low and they have a high heart rate, and so that's a very indication that dehydration has potentially occurred. Constipation is kind of the opposite problem. It can be just a primary problem that they have, slow bowels to respond, or it may be because of some of the other diseases or conditions or medications even that they're on. So really doing a good history and physical exam on somebody with constipation is really your first thing to investigate, because what is the cause of it? Again, symptoms, straining, fewer than 3 stools a week, really hard, dense stools. They may have rectal blockage. They feel like they went to the bathroom, but they've not really completely went. And sometimes they have to have manual maneuvers to have a bowel movement, such as finger evacuation or manipulation that we talked about in class last week. Sometimes this is caused by inadequate fluid intake, or they become dehydrated and their bowels have just gotten more dense. Bowel movement material has just gotten more dense. It could be lack of fiber, frequent or abuse of laxatives, different things, other diseases, and pain medications, as we know, slows everything down. Injuries to the spinal cord can also be a key cause of constipation. These are just some of the tests that would be run to kind of evaluate how much constipation or how much blockage might be there. These are your typical treatments, which I'm sure a lot of you have already seen. Some patients are going to be incontinent, and that's going to be pretty common. These are just a few of the causes. Trying to determine the issue with incontinence, some of these type of things would be the tests they would run. Sometimes incontinence can't be really solved, but occasionally you can do bowel retraining. I did put this slide in here to show you kind of if you have, there's a couple of diarrhea control devices, and there may be a few more than this now, that are actually inserted into the rectum. They don't recommend using rectal tubes anymore, but these specific type devices to contain like a large amount of diarrhea stool that's occurring. So just know that there is some apparatuses out there for that purpose. I'm not going to go into these questions, but I do want to lastly mention a few key things. I know we talked a little bit about NG tubes and the use of those post-operative or with a blockage. Sometimes they do that to kind of allow the bowel to rest after some type of GI surgery, or also when there's a blockage present. And if you have had surgery and have a nasogastric tube in, we've talked a little bit about that when we did the surgery section, but I just want to make sure that everybody understands sort of the management of that. You want it, if it's supposed to be to low wall suction or to intermittent low wall suction, to be, you're kind of constantly monitoring the amount of liquid that's coming out of it. You'll often mark that on the container every 4 hours just to keep track of how much the output is. And if you notice that on a fresh post-operative patient, one is not draining well, it is very important to think about why the person has that nasogastric tube. If it is a fresh post-op, you do not ever want to go flushing or replacing that tube until you are sure that that is okay with the physician, because you don't know exactly everything about it. So just remember that. And then, of course, any bright red bleeding through a tube needs to be reported immediately.